This presentation will discuss pulmonary edema, atelectasis, and consolidation. I have no disclosures to make. The learning objectives of this talk will be to know the imaging findings of pulmonary edema, atelectasis, and consolidation, and to be able to recognize those findings on both chest radiography and CT, and then to apply that knowledge in the practice of radiology. Pulmonary edema is a very common finding in our day-to-day practice. If you're in a hospital-based practice, you probably see many portable chest radiographs on a daily basis, and you'll see a series of those on individual patients. And by studying the serial findings, you will be more likely to recognize things like pulmonary edema and other entities to be discussed in this talk. There is some overlap of imaging findings. For instance, these two patients you see on the screen, one has pulmonary edema, one has pulmonary hemorrhage, and these findings overlap, and you can have pulmonary edema that actually mimics pneumonia, as well as acute respiratory distress syndrome and hemorrhage, as you see here. And the important thing, of course, is to correlate your observations with the clinical history. And the more you interact with your colleagues on intensive care units, you will be able to help them with the more accurate interpretation of these findings. Notice that both the pulmonary edema case here on the upper right and the pulmonary hemorrhage case both exhibit diffuse bilateral patchy airspace opacities. And if you look very closely, there's some very subtle, linear, almost reticular opacities through the ground glass, or hazy, fluffy opacities in both lungs. We know that pulmonary edema represents extravascular fluid accumulation. It's abnormal, of course, and it can be in the interstitial of the lung, or it can actually move into the air spaces of the lung if the pressures mount to a sufficient level. And we can divide it into cardiogenic pulmonary edema or non-cardiogenic, and obviously cardiogenic relates to patients who have cardiac dysfunction with elevation of the pressures, the venous hydrostatic pressures in their left atrium and pulmonary venous system. And of course, the result will be fluid accumulation in the lungs, and again, it may be in the interstitium, it may go into the air spaces, it may be in both, and you may recognize findings that reflect those anatomic locations. Non-cardiogenic pulmonary edema is found in patients who have lung injury, increased capillary permeability. It might be a patient with ARDS or low albumin. It may be someone in fluid overload. You see in this patient a pulmonary arterial catheter in place, and this is, of course, the classic way of diagnosing cardiac dysfunction and congestive heart failure. It's the gold standard. And we know that the normal pressure is about 12 millimeters of mercury or less. You can grade pulmonary edema by looking at the pressure and categorize it as mild, moderate, or severe. Now, in mild, CHF, we'll call it, you would see just simply redistribution of the vascular markings within the lung. The vascular structures in the upper lungs will be equal to those in the lower lungs. And this would refer just to findings in an erect patient. You could simulate that appearance on a supine person just because of the effects of gravity. But when we enter pressure ranges of 20 to 25 and above 25, then you are respectively going to be encountering a moderate or possibly a severe degree of cardiac failure. And the moderate range will manifest as interstitial edema, and the more severe will manifest as airspace opacity, alveolar edema. You see here three individuals, three separate patients. On the far left, the patient with mild CHF with cephalization. Here the pressure is about 12 to 19 millimeters over mercury. And notice that there are equal number of vessels in the upper and lower lung zones. And again, if this is a supine patient, that might be a normal finding, but in an erect or even semi-erect patient, you could look at the prior study and see this as a change and call this evidence of redistribution and suggestive of mild pulmonary venous hypertension. In the moderate category, you see in the center of the slide, this patient now has interstitial edema. The pressure now is in the range of 20 to 25 milligrams of mercury. And now notice that the central and perihilar vessels are becoming blurry. The interlobar fissure here, the minor fissure, is much more apparent than usual. And we have the presence of interlobular septa here in the especially in the mid and lower lung zones. And those are the curly B lines that that represent interlobular septal thickening due to edema. If the pressure should go even higher and get to ranges above 25, then the fluid can push into the air spaces and manifest as airspace opacity. It's so-called alveolar edema. It can be very closely mimic pneumonia or aspiration or even pulmonary hemorrhage. Notice now the blurred vessels are even more blurry, and there's a lot more going on here, some fluffy, indistinct white opacity in both lungs, and very subtle interlobular septal thickening, which is there. It's just harder to see now in the presence of this airspace opacity. It's easier if we focus on just one lung of each of these very same patients. You can see these same findings with the redistribution here in the patient on the far left, and the interstitial edema in the patient in the middle, the same findings we just described with the blurred vessels, the prominence of the fissure, and the very striking interlobular septal thickening representing on the radiograph what we call curly B lines. On CT, we would simply call this interlobular septal thickening. And then the last case, again, the patient with the higher pressures with alveolar airspace edema, and things are much more confusing looking, really. Very indistinct vascular margins, lots of white sort of opacity here, which looks for all the world like it could be pneumonia or aspiration, but this in fact was alveolar edema, which did reverse following diuresis. We should review the interstitial network of the lung. It helps you understand these findings. This is an illustration courtesy of Amyris Corporation, and you see in this diagram of the lung, you can see the bronchovascular structures here coming out with the airway and the pulmonary artery. The artery here is shown in blue because it's now lacking oxygen. It's going out into the lung parenchyma to become oxygenated before it returns as a vein, as you see here in this sort of reddish-colored structure. Now notice both of these vessels and the bronchoarterial structures here have this sheath of loose interstitium, sort of connective tissue, and that can become engorged by fluid, by edema in patients with cardiac failure. You don't normally see the interstitium. So this would be the axial interstitium. Think of it as being peribronchovascular. The subpleural interstitium, here indicated by the green arrows, represents a similar loose connective tissue, and it's one contiguous system, by the way. And this is in the subpleural location, which includes the interlobar fissure. So when you're looking at a fissure, you're really looking at two layers of subpleural interstitium. In the periphery here, I have arrows also pointing to interlobular septa. All these little small pulmonary lobules that you see outlined here are in communication with the others in this very intricate system of interstitial fiber network in the lungs. Now, these interlobular septa, if they become engorged and prominent on the chest radiograph, we'll refer to those as curly B lines. So, as we summarized before on those images, you have mild, moderate, or marked degrees of failure. The mild being manifesting as redistribution of circulation with cephalization of vascularity, as I mentioned before. And the moderate, think of that as patients with interstitial findings. The vessel margins will become blurred because of that interstitial sheath around the bronchovascular structures. And you see these in cross-section, especially in the peri-hilar region on the chest radiograph. They'll manifest as a blurred airway margin. We call that cuffing. That's a very old sort of radiographic term. If the fissures begin to look prominent to you on the chest radiograph, you may well be looking at interstitial edema. Especially on a portable radiograph, watch the minor fissure. It may come and go, so to speak, in terms of its prominence in the presence or in the resolution of pulmonary edema. And again, the curly B lines represent those interlobular septa. In marked edema now, again, as I mentioned, you're now getting into airspace opacity, which could mimic pneumonia or aspiration or even pulmonary hemorrhage. You saw this image before when I showed those three cases side by side, but notice how helpful it is to have the prior study as a comparison. And that's one of the most important points of this entire talk, especially in terms of pulmonary edema. You really need to look at the prior studies to see some of the changes. And now you can see quite readily that the minor fissure was barely perceptible on the prior study, and now it's quite easy to see. The vessels were much more clearly demarcated on the prior study. Now they're blurry and prominent looking, and there were no interlobular septal lines here, no curly B lines in the prior study. And now we have numerous curly B lines sort of classically projecting as perpendicular linear opacities along the pleural surface. These are much easier to see on the mid and lower lung zones. So time course is very important. The prior studies are really your best friend in terms of recognizing pulmonary edema. And you'll look for a rapid onset and rapid change in the radiograph. And that does suggest a cardiogenic type of pulmonary edema. Now, in other patients with permeability edema, such as ARDS, for instance, the edema may persist and it's not going to fluctuate so readily. And that can be a clue that you're looking at something other than cardiac failure. And of course, if you see chronic abnormalities, that suggests that there's another etiology operating in that particular patient. The vascular pedicle is a very useful structure too. It really it refers to the SVC on the patient's right and to the arterial structures here on the left. Now, this can become widened, especially in patients with fluid overload, patients with renal failure, or those with chronic congestive heart failure. The prior study here is on the right. The middle image is this patient now with congestive heart failure. Notice that the vascular pedicle, the SVC here to the arterial borders on the patient's left, notice it's much wider and it becomes a little less distinct when patients are in a state of having fluid overload. And it comes right back down to normal after diuresis or treatment of the cause of whatever is given in the fluid overload. Pleural effusions are very common findings in both volume overload or cardiogenic edema. And of course, the heart is often enlarged in cardiogenic edema. So if we compare pulmonary edema to fluid overload, again, look for the widening of the vascular pedicle in patients who are overloaded, and you'll see some dilatation of the SVC and the azygous vein. Whereas patients with cardiogenic edema are more likely to give you the peribronchial cupping, the interstitial changes that we described above. And again, pleural effusions are very common findings in both entities. If you happen to have a CT study of a patient with pulmonary edema, you're going to see things much more elegantly and more in greater detail. You're going to recognize that there's a diffuse ground glass opacity throughout both lungs. Notice how dark the air is in the airways here. Compare that to the lungs, which should be nearly as dark in the normal state. But here we have diffuse interstitial pulmonary edema manifesting as ground glass opacity. Notice the bronchovascular pairs here, the airway and artery have very blurred, sort of edematous-looking margins. And notice the fissure, it looks more prominent than usual, thickened by this subpleural interstitium. Again, 2 layers of subpleural interstitium. You could even look along the periphery of the lung and notice that here the subpleural interstitium gives you just a very slight blurry interface as well. And then the classic finding of the interlobular septal thickening. On the chest radiograph, we're going to call those curly V lines. Same patient seen in the coronal projection just reinforces those same findings, the prominence of the peribronchial vascular interstitium, the prominence of the interlobar fissures, and the interlobular septal thickening, which will manifest often as the outlines of a complete secondary pulmonary lobule. And you'll see these polyhedral-shaped lobules in the parenchyma of the lung, and we don't normally recognize those because the interstitium is usually an invisible network. The next topic in this trilogy we're doing is consolidation. Lung opacification is categorized as either ground glass opacity or consolidation. We call it ground glass opacity on chest CT when we can see underlying structures that does not obscure the vessels or the airway walls, whereas consolidation is more dense and does obscure underlying structures. So here we have a central area of dense consolidation with some ground glass opacity on either side of it, and you can see you can still recognize some vessels and other structures through the ground glass opacity. Consolidation is defined as replacement of alveolar air. You might be replacing it with exudate in a patient with pneumonia, perhaps with aspirated material in a patient who aspirates pulmonary hemorrhage, or again, pulmonary edema can become an airspace process by flooding into the air spaces when the pressures get high enough. And on imaging, you will see increased attenuation or increased density of the pulmonary parenchyma, obscuration of vessels and airway walls, and if things become dense enough in the parenchyma, then the airways start to stand out in relief against the dense parenchyma because they are containing air. And that gives you the so-called air bronchogram sums I'll show you in just a moment. A couple of entities can demonstrate the usefulness of paying close attention to attenuation. For instance, if you see an area of consolidation and then recognize low attenuation within that in the range of fat, then you are making the diagnosis of lipoid pneumonia. And the contradistinction to that, patients with increased attenuation of the lung parenchyma, you should consider the possibility that it might be on amiodarone, which can manifest with increased attenuation in the lung parenchyma. So airspace opacity, the air in the alveoli is replaced by liquid, by cells, or by both. And it might be pneumonia, it might be aspiration, pulmonary edema. As we've said, I've mentioned pulmonary hemorrhage. Once in a while, you will encounter a patient with an unusual manifestation of lung cancer. Adenocarcinoma can line the air spaces and give you a partial filling that will manifest as airspace opacity. And lymphoma can also manifest as consolidation. Those two are less common, but they do occur. Atelectasis is technically a type of airspace opacity, but in that instance, the air has been absorbed but not been replaced. You can see in this illustration, opened up the small airways here and the alveolar spaces. You can see this exudate sort of partially filling the air spaces. And it's not hard to imagine that if you pass an X-ray beam through this type of parenchyma, it will partially attenuate the beam, and you'll end up with usually some patchy, sort of almost mottled appearing airspace opacity, as you see here. This is a lateral radiograph. It's just a detailed view of the lower thoracic spine. Here's the back of the heart, and you can see that there is this patchy airspace opacity, which was in fact a pneumonia, very similar to what you see in this illustration. And this did resolve completely following antibiotic treatment. The air bronchogram sign is a very useful and a very old sign in chest radiography. Again, I've mentioned before, it just represents the air-filled bronchi that stand out in relief against the surrounding dense parenchyma that's consolidated. It does have a bit of good news. It indicates that the proximal airway that supplies that part of the lung is patent. And notice if you do get enough consolidation, as in this case where you have a frontal and lateral radiograph, it's actually obscuring the left hemodiaphragm on both projections. And this is called silhouetting. It's an old-fashioned radiographic term which doesn't make immediate sense, but just take it to represent obscuration of adjacent structures. You can see these nice air bronchograms here standing out in relief against the dense lung parenchyma. They're branching and tapering. They do not appear to be crowded together, so we're not going to invoke any atelectasis here. We would describe this as consolidation in the left lower lobe, giving increased density along the lower part of the thoracic spine. So-called spine sign that helps you recognize something's wrong here. And notice you can see the entire right hemodiaphragm. You can't see the left hemodiaphragm back here. You can see it anteriorly but not posteriorly. So this is a classic appearance of almost a lobar type of pneumonia in this patient with dense consolidation and the air bronchogram sign. If you see bilateral airspace opacity, you certainly want to think about pneumonia, perhaps massive aspiration. Patients with severe pulmonary edema can also manifest with this pattern, as well as patients with hemorrhage or diffuse alveolar damage. There are some less common causes, including hypersensitivity pneumonitis. A very unusual manifestation, again, of adenocarcinoma can be multifocal and look just like pneumonia, as I mentioned before. And occasionally you'll encounter patients with alveolar proteinosis, which can also give you bilateral airspace opacity. This patient has hemorrhage, as you see here, diffuse bilateral patchy airspace opacity and consolidation. If you have acute consolidation, as in these three examples, think about pneumonia, pulmonary edema, possibly pulmonary hemorrhage, even pulmonary infarction. And those are sort of in the order in which you might expect to find these in your practice. This patient has very dense consolidation with some air bronchograms. Some areas of lung not quite so affected. They're manifesting as ground glass opacity intermixed with this consolidation in this patient with a known pneumonia. Notice that a patient with pulmonary edema can at times have very distinct looking areas of ground glass and even approach consolidation, as you see. This patient also had some atelectasis and possibly some aspiration in the posterior parts of the lung. And notice bilateral pleural effusions, which again are often found in patients with pulmonary edema. This patient has pulmonary hemorrhage. This is a coronal CT image. As you can see, notice the ground glass opacity, but some small little patchy areas that we can call consolidation. Again, On ground glass, you can still see through the opacity and recognize some structures, vessels, and airways, whereas consolidation is so dense that you've lost that ability to see through. Subacute or chronic consolidation is seen as this patient on the left has organizing pneumonia. Notice it's quite similar to this patient with chronic eosinophilic pneumonia. You have these consolidations that are both peribronchial vascular as well as subpleural and peripheral, and these two entities are often quite similar in appearance on both chest radiography and chest CT. You can also have subacute or chronic consolidation in patients with malignancy. It might be obstructive due to an airway obstructing lung tumor. You can have granulomatous disease, sarcoidosis, as you see in this example with a very dense consolidation. And as I mentioned before, patients with the adenocarcinoma. It's an unusual manifestation, but we see it several times in our practice every year. Also, granulomatosis with polyangiitis, formerly called Wegener, can also manifest with areas of consolidation. As I mentioned before, at times the attenuation can tip you off what's going on. This patient has consolidated opacities here in the right lower lobe, but notice on mediastinal windows we can see this low attenuation within, which really read within the range of fat. And this is a patient who was using mineral oil on a regular basis, and she aspirated some and ended up with a lipoid pneumonia. Compare that with this patient who has been being treated with amiodarone for a cardiac dysrhythmia, and notice the very dense lung parenchyma here, which is even denser than some of the adjacent muscles you see here, the soft tissue. So sometimes the attenuation pattern can be very helpful. And I'll just close this section with one more image of a patient with adenocarcinoma. This was thought to be a pneumonia. As you can imagine, it looks like a pneumonia, but bilateral airspace opacities. The patient was treated with antibiotics, came back several weeks later. This had not changed at all. They tried a second type of antibiotic. That didn't work, and they finally went to a CT scan and got some old studies and realized that this had been developing over the recent months, and this was an adenocarcinoma. Again, partially filling the air spaces and therefore manifesting in a very similar fashion to pneumonia. The last section in this talk is atelectasis, which refers to loss of lung volume. This is an older image I got from a colleague and friend, Jane Judy, and notice that it's a nice image that shows you how the lung can be so beautifully fully inflated in one instance, the right lung, but notice the left lung is almost totally deflated. It looks like it's being gripped by something, and in fact, I don't have the CT with this talk, but this is actually being caused by a surrounding old calcified empyema. So that's just a nice example of how atelectasis can be in sharp contrast to the ability of the lung to be beautifully fully inflated. You can categorize the mechanisms of atelectasis into either obstructive or non-obstructive mechanisms. The more common will be obstructive, the so-called resorption atelectasis. This might be an endobronchial tumor, it might be a mucus plug or a malpositioned ET tube, for instance. On the non-obstructive side, we have so-called relaxation atelectasis, which is more of a passive type of entity. Adhesive atelectasis refers to those conditions that affect surfactant, and the last entity, syncretization, refers to fibrosis, and that can be a focal or a diffuse process. And you may find these mechanisms operating independently or sometimes in combination. This patient has the two direct signs of atelectasis. Notice the displaced fissures here and the crowding of bronchovascular structures here in the lower lung zone. This is caused by a giant bulla in the right upper lobe. The indirect signs are more numerous, and it might be increased opacity of the lung, reorientation of vascular structures, the hilum may be displaced upward or downward, the mediastinum may shift, and you can have compensatory hyperinflation in the adjacent lung, and you can have elevation of the diaphragm. This patient has a central obstructing tumor, giving us the so-called S sign of Golden, where we have these interfaces. This is the minor fissure that's displaced upward, giving you part of the S, and then a right hilar mass giving you part of the other part of the S. And notice the right upper lobe is atelectatic. It's got increased density, as you see here. we can just barely make out faint sort of bronchovascular air bronchogram sign, but this was a partially obstructing tumor, but it was enough to make the lobe partially collapse. As this collapses, the adjacent part of the lung can hyperinflate and give you this compensatory hyperinflation. Just compare the number of vascular structures in this lung compared to the other side, and you can recognize that. And also notice that the diaphragm on this side is elevated, and the hilum is being pulled up as well. So these are the secondary indirect signs of atelectasis. A couple of examples. This patient has a malpositioned ET tube. So this is a type of resorption atelectasis. The left lung is becoming atelectatic. The diaphragm is up. The lung is becoming dense and increasing density in the lung. This patient has an endobronchial tumor. Notice the fissure here is displaced anteriorly. This is mucoid impaction in these airways. This was as a result of this central tumor. And notice how crowded these are. So those are those two direct signs, displacement of a fissure and crowding of bronchovascular structures. And there are some other entities to consider in resorption atelectasis too, including foreign bodies, bronchial rupture, and even areas of stricture or stenosis. Relaxation atelectasis refers to a space-occupying process. Now, in the left example, the space is being occupied by this large collection of air, and this patient with a pneumothorax has a very subtle type of degree of tension here, with the mediastinum being just slightly shifted towards the right. The left hemodiaphragm is displaced downward. You can see the collapsing left upper and left lower lobes in this obvious hyperlucency and lack of vascular structures out here in the periphery. So that's a type of relaxation atelectasis. You can see the lung is very happy to just sort of relax, if you will, and begin to collapse in the presence of this large pneumothorax. The case on the right is a patient with a very large pleural effusion. This is another type of relaxation atelectasis, and you can think of this as more of a compressive phenomenon, where it's either a mass or a large effusion forces the lung to become atelectatic. It sort of forces it to relax by its compressive effects. Adhesive atelectasis, as I mentioned, refers to surfactant deficiency or perhaps abnormal surfactant. And we know this surfactant helps to reduce the alveolar surface tension as the surface area or volume decreases. It really protects our lungs against collapse. So there are a number of etiologies here. I won't go into all of these, but even pneumonia can cause a little adhesive atelectasis, especially when it's extensive and sort of lobar in its extent. You can sometimes recognize a degree of atelectasis in that same lobe, which will typically resolve with treatment of the pneumonia. The respiratory distress syndrome is the classic entity that has adhesive atelectasis, but even post-op patients, those exposed to smoke, patients with pulmonary emboli, and in the acute phase of radiation pneumonitis, that also induces a type of adhesive atelectasis. Cycritization, as I mentioned, refers to fibrosis. You can have a very focal area of fibrosis that you see here, again with some little upward retraction of the hilum, some loss of volume in this part of the right upper lobe, and a CT, you can see the crowding of the bronchovascular structures and the elevation of the minor fissure. And this was just a localized type of fibrotic change causing atelectasis, and this patient had a prior history of tuberculosis. So, and it typically refers to either post-infectious or inflammatory situations with fibrosis, tissue retraction, volume loss, and this is irreversible, as you might imagine. You can have a diffuse form of cycritization atelectasis, as in this patient with idiopathic pulmonary fibrosis, with diffuse loss of volume. Notice both diaphragms are up. This patient cannot take in any kind of deeper breath because their lungs are so fibrotic and reduced in volume. Notice the extensive diffuse peripheral and bibasilar reticular opacities here as a manifestation of this patient whose pulmonary fibrosis was found to be idiopathic, so he carries the diagnosis of IPF. I just want to show you briefly the patterns of lobar atelectasis. I'm just going to give you a nice set of diagrams that you can use. These do have their own unique imaging patterns, and you'll look for displacement of fissures, increased lung density, and of course these lobes will obscure the borders of adjacent structures. As in this patient, another example of right upper lobe atelectasis. This one has no air bronchograms, very dense. As you see here, the elevated minor fissure, and here's the accompanying CT. You can see the central tumor here narrowing the right upper lobe bronchus. This was a squamous cell lung cancer. And you see in the radiograph, this does obscure the right paratracheal stripe, and it obscures part of the hilar structures as well. These diagrams are courtesy of Tema Publishing. They're from a very nice teaching atlas of Dr. Mark Parker. And they just summarize what you can look for in lobar atelectasis. I'm just going to guide you through the first set, and you'll be able to use these to recognize lobar atelectasis. In this case, right upper lobe atelectasis. You see paired images here in the upper row represent the PA chest radiograph. The lower images represent the lateral chest radiograph. The first pair shows you the normal situation, and then you have mild, moderate, and complete atelectasis, in this case of the right upper lobe. The arrows point to the fissures you want to keep your eyes on. On the frontal radiograph, you're going to watch the minor fissure as it progressively goes up and becomes bowed, and the collapsing lobe will eventually become very flattened almost against the mediastinal structures on the right, and will obscure them as well. On the lateral radiograph, when you're looking for right upper lobe atelectasis, you'll look for the minor fissure as well, and also the superior half of the right major fissure. And you notice that as this atelectasis progresses, those two fissures move closer and closer into apposition, resulting in a triangular-shaped opacity. And these triangular opacities are very characteristic of lobar atelectasis, so you want to keep those in mind. Here's left upper lobe atelectasis. There's no minor fissure. You're not going to be able to follow that. On the PA radiograph, you will see increased density. On the lateral, you'll very clearly begin to recognize an interface here representing the major fissure, and with progressive atelectasis of the left upper lobe, this fissure will move more and more anteriorly, and the collapsing lobe will become more and more dense. Here's an example of left upper lobe atelectasis. The lateral radiograph is the most helpful. You see this sharp interface between the collapsing right left upper lobe and the aerated left lower lobe. On the frontal radiograph, all this increased density is going to obscure the left heart border. Notice there's a very subtle shift to the left by the trachea, and a very mild elevation of the left hemodiaphragm, and of course increased density in the atelectatic lobe. The middle lobe can be elusive on the frontal radiograph, but on the lateral, it's usually quite characteristic and easy to recognize. We're going to follow the minor fissure and the lower half of the major fissure, and these will become closer and closer in proximity, forming again a triangular-shaped opacity on the lateral radiograph that's usually easy to recognize. The right lower lobe will collapse and bring with it the minor fissure. So on the frontal radiograph, we're going to follow the minor fissure, and we're going to look for the major fissure to appear as well. On the lateral, we're going to see the upper part of the major fissure go progressively down, 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 and the lower part of the major fissure move back and back and back. And again, a triangular-shaped opacity is the result. And here's a nice triangle on the frontal diagrams as well. But notice the minor fissure comes along for the ride, and that often will tip you off that you're looking at right lower lobe atelectasis. If we go to the left lower lobe, notice the similarity between the lateral radiograph of right lower lobe and left lower lobe. Very same thing. You're going to end up with increased density over the lower thoracic spine. And on the frontal view, as this progresses, you'll begin to recognize a triangular-shaped opacity behind the heart. In complete atelectasis, right or left, you can end up with a very small triangle, and that can be very difficult to recognize when you have total atelectasis of any of these lobes, really. And I'll close with this combined pattern of both middle lobe and right lower lobe atelectasis. And you don't see this that often, but when you do, it really points directly to the bronchus intermedius, because both of these lobes, the middle and the right lower, are supplied by the bronchus intermedius. And you're going to see progressive development of this band of increased density from medial to lateral on the frontal view, and from anterior to posterior on the lateral view. And here's an example I'll just close with to show you increased density obscuring the right heart border and completely obscuring the right hemodiaphragm. And on the lateral, there is a very subtle increased density sort of front to back. And this was a patient with lung cancer, a central tumor that is very hard to even point to here, but it was obstructing the bronchus intermedius. So that's quite a quick tour of edema, atelectasis, and consolidation. Very common findings, as I've said, and you'll sometimes see these in combination, by the way. So I hope you'll find all these examples and the diagrams useful.